Hi everybody, my name is Doug Kerr and I'm going to do a presentation on integrated behavioral health. I want to start out by saying that I have been observing family medicine residents as a part of their behavioral science training for about 12 years now in the family medicine clinic at Harborview Hospital, the largest public health hospital in Seattle, where a good 30% of the people who come in for services are refugees and require translators in order to do their primary care visit. So it's mostly indigent, low-income, and immigrant folks who use that as their primary care setting. And I go there as a part of the family medicine residency training program to help the resident docs, the young family medicine docs, with mental health issues, communication issues, and treatment compliance issues. But when I'm there for a while and after I get to know the residents a little bit, at some point they will say, "You're a psychologist. What are you doing here?" I usually give them the answer as my first reason for being there, originally 12 years ago, and that's I say something to them that clearly resonates with anybody who works in public health. I say, this, family medicine, is the front lines in the treatment of mental illness. This is where it happens. 80% of the people who need mental health services never get any explicit mental health services. Only about 20% ever find their way to a specialty provider of some kind. So those conditions get treated in primary care. Primary care is where people get their antidepressants. Primary care is sometimes where people get their antipsychotics, because that's the only place where they can get their medicine. So primary care is the front lines of treatment of mental health, and everybody who works there knows it, because they know that their clients are depressed, they're anxious, they're traumatized, they have psychosomatic illnesses, they have illnesses that have gone untreated because they're poor. They're there for all kinds of reasons. And it's also obvious, one of the reasons for a psychologist to be on medical turf is that physical issues affect a person's mental status. And the person's mental status affects their physical health. For instance, people who are in pain, if they're in pain and it's unrelenting pain, it's not going to be very long before they get depressed. And once they're depressed, they tend to isolate, shrink down their life, which gives them a lot more opportunity to focus on the pain that they're experiencing. So it has a way of feeding each other, the depression and the pain. So the reason for a psychologist to be there is that's where mental health treatment happens for the largest group of people who are never going to make it to a specialty mental health clinic of some kind. Integrate what? We talk about integrated behavioral health. It's integrating medical practice with mental health, chemical dependency, psychology, social work, and marriage and family therapy. So we're importing people from all kinds of different mental health related specialties to work in primary care and pediatrics and gerontology, and primary care is the front line of the treatment of mental illness. Another reason is the efficiency of the physician's use of time. And one of my jobs in shadowing the family medicine residents is to help them with their communication with their patients in order to effectively make their time use more efficient. And as you may have noticed lately, 15 minutes is the standard primary care visit. The docs have a productivity quota, which is for the early residents, this is really their preoccupation is, can I keep up today? Will I be able to see all of the patients who are fitted into my 4 patients an hour slots? So That puts them in a bind because actually of the 15 minutes, the doc actually face-to-face time with you usually spends under 10. And the field is about to reduce the 15-minute standard visit to 12 minutes. So you're going to get very, very little face time with your physician. And probably somebody's going to screen you before you get in to see the physician to develop a problem list, which constitutes what we're going to talk about in this visit. And if there's more than 3 things on your problem list, it's not going to all get done. Sometimes only one thing on the problem list can get done, and it has to be prioritized. So the docs have worked very hard to listen a little bit, intervene quickly, solve at least one problem, set up the tests and procedures that they need to address the other problems on the problem list, and then you're out of there. That's it. It's over. So they have very, very little time to deal with people with anything more complicated than we need another test for this diagnosis, and I'm going to write you a prescription, take these pills, right? That's pretty much all that they've got time for, and they don't want to do the other stuff, right? So what is the other stuff? The other stuff is behavior changes. And doctors don't like to deal with the issues back and forth of people's behavior changes. They would really prefer to leave that to somebody else. Behavior change is a part of every medical intervention, and there are a lot of them. You know, people in here are of a sufficient age that you have all had this experience. You know the drill. Take these pills. There are the morning ones, and there are bedtime ones, and there are as-needed ones, and I'm sure some of us have those little pill cases so that we can keep it straight and not forget which ones we took today and which ones we didn't. And the other regulars that you know well: eat your fruits and vegetables, cut out alcohol, coffee, and snacks, exercise at least an hour per day. If you're smoking, you got to stop that right now. And drink more water. Eat less meat, sugar, carbs, all your favorite foods. No spicy, salty, or acidic foods. You can forget about going to a restaurant. Record your glucose blood levels 3 times a day, which means stick your finger and make it bleed. And change your dressing every 4 hours. And yes, that includes waking up in the middle of the night. You better set your alarm. Surprise! Medical compliance is a problem. Why would that be? I can't imagine, right? Just on the basis of prescriptions alone, well, 40% of prescriptions are not filled, so 60% of them are filled, and 40% of the prescriptions that are filled are not taken as prescribed. Okay? Prescriptions are the main medical intervention of medical care as we know it, right? So if we got this kind of proportion of people not complying with the basic thing that's being done to intervene with them, we're going to have more problems. If a physician is unaware that the patient is not complying with the prescriptions in the treatment program, they think that the treatment is not working. And they'll take action to correct that by increasing the dose or changing the medication, right? All of which is a giant waste of time if the person's not complying and the physician doesn't know it. If the physician doesn't know it, they may say, this treatment isn't working, maybe I was wrong about the nature of this problem. We better reconsider the diagnosis and order more tests, all of which takes time and is expensive. So knowing a person's level of compliance and helping them increase their level of compliance would help everybody. It would help the physician be able to know what they're doing, and the client would start to get better. So this is an important issue. Why is compliance such a problem? Patients have life personal issues. One of them is some people don't like to be told what to do. And if they don't like to be told what to do and you're telling them what to do, they'll either tell you to go to hell, or they will tell you that I don't believe that this is really a problem and I'm not going to do it, right? There are lots of other reasons besides reluctance and denial and discounting of the symptoms. And that's homelessness and poverty makes access to care providers difficult. Transportation mobility problems. If a person's in a wheelchair, even in hospitals, obviously getting there and getting around is going to take a long time and be a big deal. Grief, depression, and psychological trauma. Serious mental health conditions. Substance abuse or addiction. Divorce, no child care, no money. Phone disconnected, too sick, too tired, no time. Okay? All the excuses that we hear regularly. The no-show rate for primary care visits at Harborview's Family Medicine Clinic is very high, just as it is in community mental health centers. People have appointments, but for one reason or another, they don't get there. Old term was compliance, and now the preferred term is adherence. What's the difference? Yeah, compliance is definitely a top-down kind of a concept, right? We tell you what to do and then you do it. Doctors do have a reputation for being inclined towards top-downness, it's true. But actually, in order to get compliance, requires collaboration and negotiation with the patient about the plan. Patients not involved in decisions, behavior changes, fail to comply, or they actively resist the behavior changes, or they discount the seriousness of their condition. And if their condition is not serious, of course, they don't have to do anything about it. So what can be done about the problem of compliance and adherence? Ask about the obstacles that the person is having in complying. Actually spend some time and be interested in the difficulties that they're facing making this happen. Ask them about their motivation and their ability to comply. See where they're at. Find out if they think this is not important enough to be bothered with. I'm not going to do this drastic behavior change thing because I don't really think I'm sick and I don't think it's going to get worse and I don't believe it. Listen to patients' life and personal issues. You know, they've got something else big going on. They've got a sick parent or they've got a disabled child. They got a lot of other stuff on their plate, and maybe making it to their appointments or following their own treatment plan for their own illness is not their priority at this time. They got other stuff they got to attend to. Can help the person problem solve in a conversation about behavior changes. And the idea is to co-develop a realistic behavior change plan that the patient thinks they actually want to and can carry out, right? But this kind of discussion and listening and negotiation and planning takes time. Physicians do not have time for these kinds of discussions. In their standard 15-minute visit, the doctor has under 10 minutes to talk to you. And these discussions often involve 5-10 minutes of just listening to get the background of the story. Physicians do not consider this an efficient use of their time and would prefer that some other provider do it. Also, what physicians don't say is that they're not really well trained to have these kind of discussions. They don't really know what they're doing. The typical physician discussion about behavior changes, I bet everybody in this room knows, right? And that's diet and exercise. Probably all of us get a lecture about diet and exercise every time we go in at this point. And I don't know about you, but occasionally in the middle of that lecture that I've heard yearly for the last 10 years, I begin to say to myself, blah, 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 blah. I've heard this before. And it's not new and it's not interesting, and I just wait until it's over. We want someone else to be doing this job. The doctors don't like to do it, and they don't do it well. There's one cartoon I have up in my office, and it shows a physician coming out of an emergency intensive care area into a waiting room speaking to a woman who's obviously distraught because she's just heard bad news. And the doctor says, I wasn't able to save him, but I did get in one more lecture about diet and exercise. Mm-hmm. Speaks to the futility of continuing to repeat yourself. You know? Physicians don't like to do this. They don't want to do it. They want someone else to do it. They haven't got time to do it, and they're not really very good at it anyway. So, because when you're a physician, when you see them, if you've got a chronic condition or something that they speak to you about every time, they will reiterate all of the reasons there are why you should comply with what they're telling you to do for your treatment program. And that explanation usually involves predictions about the future. If you don't, here's what's going to happen to you, you know? And we go through the steps of that, and it usually ends with, and you're going to die, right? And you're going to die is one of the least motivating statements that you can say to a person, although it's probably intended to be motivating to them so that they can avoid death. Actually, most patients, when they hear at the end of the things that are going to happen to you if you don't comply, you're going to die, they say, well, I'm going to die anyway. Maybe I should die happy. And I'm going to go on doing this, right? Because I'm going to die anyway. And of course, we're all going to die anyway. The question is when and how well are we going to live between here and there? So threatening patients with, you're going to die, a horrible death, right, is not motivating. So the new idea in health is the health home, the creation of a health home team. And we'll talk a little bit about this. This is the new movement now. Psychosocial and compliance issues can be delegated to non-physician team members who have skills in behavior change and counseling, including counselors, mental health counselors, substance abuse counselors, marriage and family counselors, and child behavior specialists. Medical providers such as nurses, medical assistants, physician assistants, nutritionists, and physical therapists would all be part of the integrated team. So let's talk about this in terms of a patient. So I made up a composite patient. This is not a real patient, but I feel like I know her already. I've seen her 1,000 times. Alicia is a 35-year-old Caucasian woman. She lives in low-cost housing with 3 children, one of whom is disabled. Alicia suffers from diabetes, obesity, lower back, and limb pain. So that's a configuration of serious symptoms that frequently goes together. Diabetes goes with obesity, as does lower back and limb pain. Bad knees, bad hips, bad ankles, sore feet, right? Everything below the middle of you is taking whatever weight you're carrying, and it's likely to hurt at some point. And it's likely to get better more slowly if you're overweight. So one problem potentiates another. Alicia's 3-year-old son was born low birth weight and premature with sleeping, eating, and behavior problems. Any of those of you here who have had a child with sleeping, eating, and behavioral problems when they're young know that this is a major stressor. It's 24/7, there's no escape, every night, every day. Alicia has a part-time job through her church and receives SSI and Medicaid benefits for her son. So she's able to support herself more or less between that aid and her part-time job. Alicia is depressed. She has several chronic medical conditions requiring complex care that can cause hospitalizations if uncontrolled. Just getting to her and her son's medical appointments, parenting her 2 other children, working half-time are stressful, as well as physically demanding and painful. When you've got lower back and hip and knee and foot pain, and you've got 2 kids, there's a lot of moving around, and it's going to hurt. Sometimes she sleeps 12 hours straight, and that's a combination of, those of you who know about ongoing pain, it's really tiring. It just wears you out. And she's depressed. And depressed people would prefer to be in their beds with their covers pulled over their heads if whatever amount of time they can get away with it. And the pain makes her tired, irritable, and depressed, which makes her less of a good parent and probably less of a good employee. Alicia needs a home health team. She will have regular brief visits with her physician for physical exams to review test results and revise her treatment plan. But that's going to be the least of the services that she's provided with. She'll be in frequent phone contact or electronic contact with a medical assistant to report her blood glucose levels. Okay? This telephone contact is the regular now, but it's actually moving in the direction of telemetry, where people do continuous readings and they wear something that's transmitting, and the provider can get electronic transmissions of continuous readouts of blood glucose level. So that's the direction things are going, and monitoring really helps. Well, I've been talking to people about diabetes for over 10 years, and they used to ask the patients, they'd give them a sheet day by day, and they were supposed to write down their blood glucose levels 3 times a day as they were taking them. Well, guess what? It didn't happen. They didn't write them down, or they forgot to bring them in with them for the visit, and there was no feedback, and then we have to rely on people's memories. You say, okay, you've been doing the readout, how many times in the last week were your readouts above 200? And we know people's memories are really bad, right? And some people will exaggerate that, it's been almost every day, and other people will say, only once or twice in the last month. And that bears no resemblance to reality and does not help them to control their diabetes. And maintaining steady levels by close monitoring avoids tissue damage and hospitalizations, okay? Having your glucose level swing wildly out of control on a regular basis is going to do damage, and it's going to be noticeable damage in a relatively short time. So the idea is to stabilize your blood glucose level so it's never way too high and it's never way too low, and that requires a lot of behavioral adjustments. Alicia needs a lot of people on her team. She needs a mental health counselor for her depression and behavior change related to her diabetes, her obesity, and her pain. Okay, so what are the behavior changes related to obesity? The first one is check your blood glucose levels. The second one is change your diet. And the third one is get some exercise, right? And if you've also got pain, it's going to be do your lower back stretches, right? So with each condition, we're adding on to the number of behavior changes that's being expected. Dietitian, she needs a dietitian to help her with her diet related to the diabetes and obesity. She needs to be on a weight loss program, and that's the idea of that is that it's going to save her lower joints before they need to be replaced. She needs a physical therapist and an exercise program for her back and lower limb pain, as well as the obesity and the diabetes. She needs a psychologist and a pharmacist in a pain clinic to treat her pain, depression, and behavior change. Okay, Alicia needs a lot, but Alicia's also got several things going for her. I know from this scenario that there are some other things that she doesn't have. First of all, she's got a job, which is something worth keeping. She's getting welfare for her son, but she's not reliant on welfare for her own support. She's not substance abusing, which is often a part of this picture and makes all of the fixes more difficult. And she doesn't have a history of abuse and trauma, which many people in these circumstances have, and that also makes all of the other therapies more difficult. So, doesn't have a trauma history. She's depressed, but she has a job and she has a healthcare team. So she still has major challenges and burdens, but she's got some of the things that she needs to make it through. She also needs a care manager to help her with her SSI, Medicaid, and housing, especially with a disabled son. She's going to need wheelchair access, everything, probably going to be in affordable housing of some kind that has some proximity to a medical facility where she and her son can get if they need to get there quick. Care manager also provides team coordination and appointment coordination, and a child development specialist for parenting a disabled child. Team coordination and appointment coordination, of course, becomes really important when you have several different providers. They need to know what each other is doing. They need to know how it's going with what the other people are doing. And most importantly, for somebody under these economic circumstances and with difficulty with mobility, we want a team coordinator who's going to line up her many visits with each other so that she can come into the hospital and see one of her providers and get her son into another provider on the same visit, because getting there and getting back home may be a big difficulty. So to the extent that the healthcare coordinator can coordinate the visits, can also make sure that test results are available when they're needed, and the provider that she's seeing has all of the notes from the other providers she's seeing at the time that she arrives. That's no mean trick. Health homes require communication and collaboration across provider disciplines. These disciplines have jealously guarded their turf for decades. Mental health, medical, never the twain shall meet, right? We operate by different principles, and we have whole different ways of doing things, and usually we fight over the few clients who might actually make it to mental health. So we have to give up some turf, we have to give up some control over our disciplines in order to coordinate and provide across providers. Physicians need to cede some coordination and decision-making exclusivity. That might be a bigger obstacle than it appears at first. Doctors like to call the shots. They do not like the thought that there's somebody else on the team who could make critical decisions, or that their decisions could in any way be overridden. So this is one of the obstacles. Is in order for the physicians to have these providers on their team so that they don't have to do the stuff that they don't want to do, they got to give up some decision making. And mental health counselors have to give up some things too. They have to adapt to a 15-minute counseling schedule, and the sessions have to be hyper-focused to be completed in that time, and they have to do extensive information sharing, which mental health folks are not used to and generally don't like to do. They have a much stronger ethic of confidentiality than medical providers do, and they don't like their psychotherapy notes being kept on electronic databases. These things will all get worked out, but right now that's what some of the obstacles are. The mental health folks don't like the information sharing the way it is. They don't like the 15-minute visits, and the doctors don't like giving up decision-making power. But they're figuring a way to work it out. So this all sounds good, right? A full team with full service, all of your life issues can be dealt with in primary care or next to primary care. So people often ask, well, why hasn't this happened already? And it is happening. It's been happening in fits and starts for about 20 years now. And several large groups have adopted integrated behavioral health as their main MO. Group health has done so maybe 5 years ago. Veterans Administration probably started 25 years ago. Federally qualified health centers is something that you may not have encountered yet, but federally qualified health centers are springing up all over the place. This comes from grants that were associated with the Affordable Care Act, Obamacare, to start clinics all over the country to provide for the Medicaid expansion. Near my office in Lake City, we have a place called Neighbor Care. They're building the building up from ground level and going to staff it. It's going to be the local health center. In the neighborhood where I live in Greenwood, there's a new health center going in, federally qualified health center being built that's going to be done on the integrated health model. School clinics are going to be outreach from either mental health or from primary care settings, but there are going to be health care clinics in schools all over the country so that the primary medical care can be provided at school. making access obviously a lot easier. HealthPoint is a pioneer in the territory of integrated behavioral health. HealthPoint was different. They managed to sidestep all of their financial complications of setting this up because they have some kind of an enormous legacy inheritance. Some rich person bequeathed them enough money to operate virtually in perpetuity without having to charge low-cost patients at all. They still, collect Medicaid and Medicare, but they can see people who have nothing, no resources whatsoever. And one of our students, recent graduates from the Ph.D. program, did a internship at HealthPoint in South Seattle. And before she was even finished and licensed, she got a job in a school health clinic in Federal Way, because there aren't very many people who have experience in training in this, and as they open these new places, they're going to snap up anybody who's had experience in training. The Everett Clinic has also fully integrated in the Everett area, and I'll talk in a moment. The Everett Clinic did a joint pilot study with Regents and Boeing to show how integrated healthcare can save money. Why is this happening now? This is happening now to a large extent because of Affordable Care and Patient Protection Act, Obamacare, but it was really started before that. Obama and the initial Romney plan were onto this integrated behavioral health a long time ago. Obamacare is based on Romney's Massachusetts plan, and integrated health was a critical part of both of them. So this predates the 2010 law. FQHCs and school health clinics are prompted by money that came with the passage of that law in 2010. And the Medicaid expansion is coming up. The figures are in dispute about Medicaid expansion, but it's going to be somewhere between 16 million and 26 million new customers coming into the healthcare system. The reason there's such a disparity between those numbers is that they're originally saying there would be 30 million new customers, but since the Supreme Court decision allowing states to opt out of the Medicaid expansion, they don't really know what it's going to be, because the states have not yet decided about whether they're opting out of the Medicaid expansion or not. But the low end is going to be 16 million. 16 million is still a lot of new patients. It's a lot of new patients. Many, many more new Alicias will be entering the primary care system, which is already short of physicians, especially rural physicians. So the workforce intended to support this enormous expansion is not yet in place. Some things have changed that have made this possible. And one of them is what's called accountable care organizations, ACAs. Fee-for-service medicine is losing its grip. Previously, provider groups could not bill for things like auxiliary services like care managers. This wasn't happening because there wasn't any billing code that you could be reimbursed for it, right? The care manager services were not paid for. That's starting to change from a couple different directions. There are additional codes coming out within the healthcare system that does allow you to bill for case management, but more importantly is a change that insurance companies are experimenting with innovative reimbursement systems based on health maintenance and wellness promotion for defined groups of customers. So this is called capitation. You may have read about capitation, where an insurance company contracts with certain provider groups in a mix that covers the whole territory, and they offer the provider groups a set amount of money to provide services to this discrete population. And they are then offered, they're given that amount of money, and if they don't need all of that money, they get to keep the difference. But if their costs exceed the base amount of money that they're being provided with for this population, then they bear the costs. So there's all of a sudden enormous incentives built in for the providers, especially the physicians, to cut down on the expensive stuff that they regularly do. Now, why do doctors regularly do expensive stuff? They do expensive stuff because they get paid for everything that they do, right? Every new stuff that they do, they get more money for it. And that's the fee-for-service model. And it's very hard to think about reducing costs when, in a doctor's frame of reference, not doing this test is costing me money. Right? If I do this test, I make money. If I don't do this test, I don't get to bill for that. Right? So having the coverage for the people rather than for the procedures will make the costs come down, because the incentives for the doctor to do tests backwards and forwards are greatly reduced. Another part of this has to come with medical malpractice. Tort reform is also required because a lot of the extra tests that doctors do are basically CYA, so that if anything goes wrong, they can say, well, I did everything that I could do. And that's their defense. And the healthcare spends millions and millions and millions of dollars on unnecessary tests that are just liability protection for the physicians. Insurance companies contract with provider groups. Investments in preventive care and chronic disease management then become feasible, right? If we have discrete populations that we're treating. And chronic disease management is the big cost. So if you can provide for people with chronic disease who are not managing it well, that's where cost savings can happen. These folks are called high utilizers. In public programs, 5% of the patients account for 50% of the costs. Okay, so if we're looking to save money, that's the group that we want to look at. The recent Everett-Boeing Regents pilot study targeted high utilizers among Boeing employees whose costs were mostly due to poorly controlled chronic diseases, frequent hospitalizations, and those were caused by poor adherence to treatment programs. Okay? So these are the people who cost a lot of money. And in the Everett-Boeing Regents pilot study, they provided these folks with care managers and care teams and stayed in constant contact with the people who were viewed to be at greatest risk for being hospitalized because they lost control of their chronic condition. So they just poured on the attention and contact by care manager types who are middle-level nurses or low-level counselors, right? And I got to be involved in this because I got a contract from Everett Behavioral Health to train a whole cohort of new care managers in motivational interviewing to help them speak to their clients about behavior change. So they were interested in doing that, they were willing to invest in it, and they were willing to invest in it because the Boeing Regents pilot study showed that if a lot of attention was focused on the people who cost the most amount of money, hospitalizations and costs could be brought down. So, improved outcomes and cost savings. Patients like the extra time and attention as well as the better health outcomes. Physicians like to leave the psychosocial and adherence issues to others. Insurers like the lower costs, particularly fewer hospitalizations. And non-MD providers like the job opportunities, variety, team collaboration, better pay, and benefits that come with these new jobs. Access for patients is greatly improved because all within your primary care clinic, you can just walk down the hall and the physician can do what's termed a warm handoff. That is, your physician leaves your primary care visit meeting with you, walks down the hall, knocks on the door of the behavioral science person, and introduces the client to this person and says, this person will help you with what we were just talking about, be that depression or anxiety or trauma, right? And client shakes their hand and sits down in the room on the spot and is introduced, and that's their first visit, and go for 15 minutes. But the chances of the person following through after they've shaken the new provider's hand and sat down in their office and talked with them for 15 minutes, the chances of their following through is much greater than the old model where they said, okay, 2 blocks away down there is the mental health clinic. Go on down there and talk to them about making an appointment, right? They never make it. It hasn't worked. You know, people are intimidated about going into facilities that deal with people who are mentally ill. You know, if they make it past the receptionist, they go and sit down in the waiting room, and there's somebody having a psychotic break in the waiting room, and gone. I'm out of here. But in the primary care clinic, they get a warm handoff, they get a brief visit that's coordinated with their other visits. The 15-minute visits have to be extremely focused, so we have a priority list of the conditions that you're being treated for, and we sit down and we get to work. Unfortunately, for 15-minute visits, it's going to now be that these counselor types are sitting there with their laptops in front of them, typing their notes just like your primary care physician does. Because you've only got 15 minutes, they don't give you any extra time for documentation, so you've got to do your documentation on the spot while the visit is happening. You probably noticed that with your doctors these days. They type while they're talking to you. So it's focused on the treatment goals. The person who's providing the behavioral science services stays in contact with the care manager, who's in regular contact with the patient, so they know how things are going, and if they start to go south, they can intervene quickly. There's coordinated care, and there's timely information sharing. So it's all there. You come in for your visit, it's all there at once. Influx of millions of new patients are going to cause workforce shortages. Workforce shortages, which are already present in rural areas for primary care physicians. These workforce shortages will necessitate service delivery changes. It's going to require role changes. Efficiencies and teamwork will be critically important to making this happen. And most of the current people in the workforce have had no explicit training in teamwork or efficiencies or obviously in the new roles. And even if we do all that, it's not going to be enough with all of those millions of new patients. Workforce expansion and training. We're going to need many more workers who are trained to do these new jobs for new organizational structures, new roles, and paid for in new ways. They need to be trained in teamwork and collaboration, trained in the responsibilities and limitations of these new provider roles. And they have to be trained in a common vocabulary and sharing an information system, because this was foreign turf for most of these other providers until recently. Are we ready? Extensive change is underway in the healthcare system, and it will be a huge challenge. Change cannot be expected to go smoothly, especially given the politics of reform. Okay? We're not going to know anytime soon what states are going to sign up, what states are going to expand Medicaid, what states are going to create insurance exchanges. But Washington State has been a leader in the development of the insurance exchanges and will be ready for implementation in 2014. In fact, the plans for the insurance exchanges are due in Washington in January. And Washington will be done, and they will submit theirs. However, other states, most notably Texas, has refused to even begin to create the insurance exchanges because they're holding out for the possibility that Obama won't be reelected and they won't have to do it. And that should create an interesting showdown, Texas style, because in January, if they haven't submitted a plan, according to the law, the federal government will provide them with a plan for their insurance exchange. That'll go down really good in Texas. Time for training an integrated behavioral workforce is now. We don't have the people to do this. We're going to need the people to do this. It's already happening. So I guess that's just time enough for my plug. We happen to have a new continuing ed certificate program in integrated behavioral health, just in time for the training need of the new workforce.
So are there other programs available in the state for like that certificate training right now?
Well, I went out to Navos, which is a big mental health center empire, yesterday to see their new facility. They have a beautiful community mental health center there, and they now have a primary care clinic in the community mental health center. And these jobs are going to be done by the current existing staff at the community mental health center. And I, of course, was interested in how they were going to get their training for this, and they got a grant from the Substance Abuse and Mental Health Administration, SHAMSHA, for 2 days of free training for trainers out of Washington, D.C. So free is obviously good, but 2 days is utterly and completely inadequate for training people to do this task. Good, thank you.